Hello, everyone. I'm Associate Professor Dr. Tan. I come from University Kebangsaan, Malaysia. Our country is a middle-income country, which I'm currently working in a university hospital in the emergency department. Our hospital is a 1,000-bed hospital, whereby we have a range of patients from a very poor socioeconomy to a very high socioeconomy background. So today I have an opportunity to share with you some of my experience in sepsis management, especially the pitfall while managing them in our setting. I would like to declare that I don't have any conflict of interest that have any involvement in any organization or entity which have any financial interest. So everyone already know that Sepsis 3 definition is already implemented since 2016, and there is a very various of scoring system to help us to identify sepsis early. Sepsis definitely is a life-threatening organ dysfunction that caused by the whole dysregulated response secondary to infections. So the common scoring involves SOFA score, maybe a quick SOFA, acute SOFA, or M-SOFA, which is modified SOFA. As for the dysregulated whole response, we have this search criteria, which is very familiar. And also we have other scoring like MAS, CAS, or PICS. And definitely the infection source can become from bacteria, fungi, prions, virus, or parasite. Let's go back to basic. Let me explain again about classical shock model. The classical shock model definitely is based on the hemorrhagic shock and cardiogenic shock. When a patient who have adequate reserve, they have involved in insult such as like trauma with hemorrhagic or patient having a myocardial infarction, definitely will lead to a cardiac failure or the volume failure or volume loss that leading to circulatory shock. When the circulatory shock happen, it causes the cellular hypoxia, cellular hypoperfusion, and lead to cellular shock and cellular death. This event can happen within minutes to hours. So that's why this is an acute event that we need to attend fast, especially when you're having a hemorrhagic shock. We need to stop the bleeding. For the cardiogenic shock, we definitely need to do a thrombolysis. Yeah. However, for the septic shock model, there's many school of thought. The septic shock model definitely is more complex. It's not like a direct one cause leading to another. Septic shocks definitely come from infections. Then when the infection is decompensated, then it leads to sepsis, which is organ failure, and later becomes circulatory shock. Yeah. So sepsis definitely leading to the cellular hypoxia, cellular damage, and leading to circulatory shock. So this is a bit different from the classical shock, which is the cellular shock first before the circulatory shock. So this happened within hours to days. That's why maybe the word chronic event will be more appropriate to describe this septic shock model. So patients with risk and with infection, definitely in prolonged infection, they have high demand on energy and low reserve and exhaustion and hormone derangement that cause all this problem. So for these two models, you compare head to head, there's some difference in the basic pathology and which may lead to a different way of approach of management of each disease. Yeah. The point number one that I want to highlight is that sepsis may be a chronic event rather than an acute event, which we need to attend it like now or do it fast. But we need to attend it fast because sepsis is an emergency situation. Definitely we need to approach it fast, but we can do some assessment first before we jump into need to do action and resusc immediately. Yeah. So we can take some hours before we run into the treatments which is appropriate to them. But doing so, we can buy time with using the inotrope or maybe using giving some fluid so that, and also antibiotic within hours. So this is more appropriate for sepsis approach. For point two, sepsis can be biphasic. Yeah, sepsis can be hyperinflammation or hypoinflammation. Some school of thought saying that this is a sequelae of the sepsis. Maybe from early starting of the sepsis is more to hyperinflammatory, but in the later set, maybe patient will have more hypoinflammatory situation. which is during the hyperinflammation, patient has an overwhelming of the cytokine production and causing the vasoplegic, vasodilation, and leading to early organ failure. However, for hypoinflammatory is that when patient sepsis is prolonged, either patient takes some medicine or patient have a good reserve before that, they fight a long war before, maybe fight for a few days, 2 weeks, then the body reserves start to exhaust, and also there's no more substrate to let the patient to fight the infection. So it become more immunosuppressed, less inflammation. Patient is like a hibernating state and leading to organ failure. This organ failure is more to late organ failure and late death in sepsis. Why these two phases are important? Because the treatment can be different. Because in a patient with hyperinflammation, we are more to suppressive. For the hyperinflammatory type, maybe we need to be more supportive on in terms of the management. So for the point 3, sepsis can cause cellular metabolic derangement. For early sepsis, definitely patient have more energy, more substrate, more reserve. That's why I can say patient have more overwhelming reserve, and patient have more hyperinflammatory state. Definitely the sugar will be high because of cortisol, and also lactate will be high due to hypoxia and a bit of maybe normal or mild elevated ketone. However, for late sepsis patient, definitely patient have poor reserve, patient have poor appetite. Then the glucose definitely will be a bit normal or lowish, but the lactate may be low because of lack of pyruvate. Even though in hypoxia, lack of pyruvate can not produce lactate. So that's why the lactate may be normal, maybe near low normal in our center here. And ketone may be high because it have to substitute the glucose, which is low. We go back to the fundamental again. As for your information, each organ have their favorite food and favorite field to function. When you understand about organ, you need to understand what they take or what they use to produce energy in order for this organ to function. For the muscle, when it's resting, they are using the fatty acid. However, when the active muscle movement, definitely they use the glucose only. However, for the kidney definitely is using glucose, which is the major fuel for the kidney. That's why when patient have a prolonged sepsis, the glucose haywire, especially insulin sensitive, definitely the glucose is impaired. And the kidney unable to use the glucose effectively and leading to kidney failure. That's why when you see a lot of patients with sepsis usually come in the first organ failure, which is the kidney failure or kidney injury. However, for those other organs, which is like liver only use ketone, they don't use glucose. That's why they can store more glucose in a normal resting state, even in an active state. For the heart, we only use the fatty acid as a main fuel. However, they can use a little bit of lactate and glucose. That's why in hypoglycemic situation, the heart won't stop. This is the wonder of our organs. They have a very prioritized substrate to be used to maintain their function. For the brain, definitely they can use all the substrate. So this is more important because when you don't have glucose, you've got ketone. No ketone, we got free fatty acid to compensate. Point 4. When the sepsis management include early nutrition support, definitely in nutrition is utmost important management for sepsis because not all sepsis is due to bacteria in origin. It can be a viral, can be parasite or for fungus. So antibiotic alone is not enough, but the early nutrition support, especially for viral infection patient, definitely this is the only way to cure them, only way to help them. In sepsis, without shock, host able to compensate with limited reserve. But in the septic shock occurred because of the reserve is already exhausted and because of prolonged overwhelming cytokine production, it causes lacking of the substrate for the host to use to fight the disease. So this is a cellular starvation. That's why early replenishment of the nutrients show good outcome of sepsis patient. Recommendation for Survival Sepsis Campaign 2021 for adult patient with sepsis and septic shock who can fat enterally. We suggest early, especially 72 hours within, initiate the enteric nutrition. So number 5, serum glucose doesn't mean that equal to intracellular glucose level. Yeah. So in a patient who have normal physiology, definitely serum glucose is equal to intracellular glucose. Why this is the equation? Because there is insulin that affect the glucose uptake from the serum to the cell. When patient in sepsis, definitely patient have insulin insensitive. Insulin insensitive can be due to the hormone or cortisol hormone that influence the insulin production, or due to the low production of insulin that also can cause the glucose unable to enter the cell. So that's why when you have a serum glucose, it doesn't reflect the intracellular, the sugar is enough. Sometimes when you see the serum is high in the serum, then you have to suspect that this patient might have intracellular hypoglycemia. So that's why insulin is important, and insulin should be measured if possible, and insulin should be combined during the resuscitation of the sepsis patient. So if we know that there's no any device can measure intracellular hypoglycemia, definitely. So you can use lactate to advocate this, which is when you have a lower lactate level, especially less than 1 millimole. Here in Malaysia, I think we have a lot of patients who have less than 1 millimole per liter lactate, which indicate that the cell is depleted of pyruvate, which they're unable to convert into lactate even though patient is hypoxia. How we suspect a patient who have insulin insensitive now, meaning that the patient unable to compensate, especially when the serum glucose is more than 10 millimoles per liter, when the patient have metabolic syndrome, patient is obese, BMI is more than 30, or patient with diabetic mellitus, which is on insulin or on oral anti-glycemic agent, or patient with a persistent high ketone, and also persistent hyperglycemia, it mimic the DKA, diabetic ketoacidosis state, or after you giving patient some boluses of dextrose when patient hypoglycemia, right? Suddenly the sugar shoot very high and remain high without any sign of normalization after hours. This is important because glucose play a very important role in sepsis management. High glucose means that patient is insulin insensitive. Maybe the cell is lack of glucose because of the serum cannot go into the cell. The recommendation of Survival Sepsis Campaign 2021 for adult with sepsis or septic shock, we recommend initiating insulin therapy at a glucose level more than 180 milligram per deciliter or 10 millimole per liter. And the evidence is moderate. This is important to play around with sugar. Okay. For point 7, sepsis with dehydration. Fluid resuscitation is the most common challenging issues in emergency department, especially when you see a patient with septic shock. We don't know whether we want to put more fluid or less fluid. More fluid can cause edema, less fluid can cause hypovolemia. So judicious balance of crystalloid replacement rather than big bolus of crystalloid should be given, meaning that you can give smaller boluses rather than a big boluses in one shot. And you can also give a fluid infusion guide with hemodynamic measurement. You can use ultrasound. There's a lot of gadget or machine can help us to monitor and guide our fluid infusion. But the SSC have suggested against the use of gelatin over the crystalloid when resuscitating a patient with sepsis. And when require a large boluses of fluid replacement, patient needs albumin replacement. Important. The pitfall here is that when we give fluid, especially give crystalloid, patient oncotic pressure will start to drop. Osmolarity pressure will be lower. So we need to assess the oncotic or osmolarity pressure. Point 7 also, according to recommendation of Survival Sepsis Campaign 2021 for patients with sepsis-induced hypoperfusion or septic shock, we suggest that at least 30 ml per kilo of IV crystalloid fluid be given within the first 3 hours of resuscitation. So this quality of evidence is a bit low, but this is important. First 3 hours. For the second recommendation for fluid is that for adult with sepsis or septic shock, we suggest use dynamic measurement to guide fluid resuscitation over physical examination or static parameter alone. And also the third recommendation is that for adult with sepsis or septic shock, we suggest to use albumin in patients who receive large boluses of crystalloid. This is moderate evidence. Next, point 8, shock and hypotension in sepsis doesn't equal to distributive shock. Distributive shock in sepsis, definitely classically we blame on cytokine production and cytokines causing the vasodilation. But Remember, there is also another way of causing vasoplegic, which is low in ATP. When the patient reach exhausting state after prolonged of infection, a low appetite, low intake, definitely have low ATP in the cell. When the vessels having a low ATP, they can cause vasoplegic as well. So this vasoplegic cannot be reversed by vasopressor. It only can reverse by giving ATP, which is giving the food or glucose. So that's why you have to remember, when the patient has septic shock, doesn't mean that they only have distributed shock. They can, but in the septic shock, you can have other shock as well concurrently, such as like hypovolemic shock. How you're going to suspect that the patient having other shock, such as like hypovolemic shock? It usually associated with acute loss of fluid, such as having a lot of diarrhea or vomiting, or patient also have septic cardiomyopathy and he might have cardiogenic shock as well, and also have obstructive shock when the patient have pleural effusion or pericardial effusion, which is massive, and also can be a very difficult to detect type of cellular shock, which is low in ATP. And when you have low ATP, definitely after you resuscitate the patient will stay in a refractory shock, even though you have given all kind of drugs. So pitfall here is that when you have a vasodilatation in sepsis, it doesn't mean that it must be due to cytokine, but also can be due to low ATP. This is what I want to highlight here. So the reversal can be different. For cytokine, it can be reversed by vasopressor. However, for lack of ATP, food or glucose is more important. Point number 9. Hyperinflammatory septic shock, definitely we would follow the hour 1 bundle. We can resuscitate the patient, replenish the patient together. Then you can give bolus of fluid. You have to give the antibiotic as soon as possible. Start inotrope or vasopressor as soon as possible. Give steroid. Maybe you need to give high dose to suppress. During COVID time, we use a lot of dexamethasone, and also you can use anti-leukin in a patient with cytokine storm, and also we have start VTE prophylaxis, early feeding, albumin replacement if patient hypoalbumin, and also good glycemic control. However, for point number 10, patients who have hyperinflammatory shock, I think replenishment is more important than resuscitate. Meaning that we take some time, give some time for the body to kickstart again. Patient shock can be chronic shock, or patient already gone through a few weeks before he come to you. Maybe the perfusion is already low, but the body able to compensate a minimum perfusion for the cell. So when they come to hospital, we just give their time to replenish them before we start to resuscitate them. Because if you hurry for resuscitation, definitely will push the patient to decompensate very fast. Maybe because when the patient come in, patient have low in glucose, low in hormones, low in minerals, low in all kind of substrate, we can replace first. When we replace, definitely the hemodynamic will come back very fast, and slowly they will stabilize. However, when we rush through to start a vasopressor or to start inotrope very early, it might not resuscitate the patient, but in fact, it pushed the patient to the other edge and using their remaining ATP, which is already low, and deplete it and causing more harm to them. So replenishment is more important in such a situation. And then the antibiotic, antiviral, antifungal should be started early. Fluid should be more to small boluses, and later on only we start to give food, give boluses of sugar, glucose. And if you want to start vasopressor, you might start a low dose, and delay the low dose while you replenish the patient. And to start glucose and insulin early or early feeding is important for this type of patient. To replace all the hormone as well is important, especially insulin, or replace the hydrocortisone, hydrocortisone to replace the cortisone. So, and also you should give the trace mineral and also the vitamins, which is important as well. So remember, a good MAP for this type of patient doesn't mean have a good perfusion because of the vasoplegic due to lack of ATP rather than vasodilatation. So take home message: sepsis may be a chronic shock, and it doesn't mimic the classical shock model. So sepsis can present in biphasic, which is the hyperinflammation, hyperinflammation, which is important because when you can differentiate these two, the definite treatment will be different. For the septic shock, it can also consist of 5 types of different subtype of shock. It can be for early sepsis, definitely the glucose can be high, the lactate can be high due to hypoxia, and normals like elevated ketone. For the late sepsis, the glucose may be normal or low, but remember this is a serum, yeah? And the lactate can be low because of no substrate to convert into lactate, and also ketone can be high due to starving. Hyperinflammatory septic shock, we resuscitate and replenish together, yeah? However, for hyperinflammatory shock, I suggest that we replace all the nutrients, replace all the hormone, which is replenished first, then slowly resuscitate the patients. Thank you for your attention and hope that today's lectures can give you some insight on approach sepsis in the emergency department.